Hey everyone, it's Jessica again, and welcome to CritIC, the Tox Series. Toxidromes are a collection of symptoms frequently seen in poison patients. Recognize the toxidrome and you'll have a better understanding of what the patient has taken, how to treat it, and to anticipate for problems to come. This video covers the anticholinergic toxidrome. Let's do this. The anticholinergic toxidrome resembles the sympathomimetic toxidrome a lot. Anticholinergic means the blockage of acetylcholine, which is a neurotransmitter responsible for the activation of our nervous system through the muscarinic and nicotinic receptors, with a profound effect on the parasympathetic nervous system. So blocking these would obviously cause sympathetic-like effects. There are a few important differences though, so let's go through this toxidrome. When assessing the patient with an anticholinergic toxidrome, this is what you'll typically see. In A, an open airway. In B, these patients could have an increased respiratory rate, but it's usually normal. Oxygen saturation and lung sounds are typically normal as well. In C, tachycardia. Fortunately, life-threatening tachyarrhythmias are only rarely seen. Get an ECG though. Blood pressure is usually normal or increased, but in severe cases hypotension is seen. This is probably due to dehydration. In D, they have dilated pupils which are equal but not reactive to light. This helps you differentiate between the anticholinergic and sympathomimetic toxidrome. Their EMV is normal without lateralization, but these patients are confused as hell and could be hallucinating. They're not necessarily agitated though. Consider benzodiazepines in severe delirium or agitation. Don't give haloperidol as this has anticholinergic effects itself. In E, in contrary to the sympathomimetic toxidrome, these patients have decreased or even absent bowel movements, and they are visibly dry mouth, no tears, no sweating, urinary retention, so give them a catheter, and dry but red and warm skin. They feel hot as hell. There is severe hyperthermia, which as you know could lead to several metabolic changes like hyperkalemia, dehydration, and rhabdomyolysis. Cool down your patients with cooling blankets and IV fluids, and watch out for ileus. Through our ABCDE assessment, we figured out that this is an anticholinergic toxidrome. Differences with the sympathomimetic toxidrome are unreactive pupils, absent bowel movements, dry skin, and urinary retention. We can thus anticipate for possible complications like hyperthermia-related metabolic disorders. We should therefore get the appropriate blood work, an arterial blood gas, liver and renal panel with electrolytes, CK, coagulation panel, etc. And don't forget the tox screen. And we've also already started the appropriate treatment, a urinary catheter, cooling, and IV fluids, and we've considered benzodiazepines. Move on to risk assessment. Can the patient tell you what he took, when, etc.? Examples of anticholinergic agents are atropine, spasmolytics like biparidine, oxybutynin for urinary incontinence, first-generation antihistamines like chlorphenamine, anti-Parkinson agents, and scopolamine for motion sickness. And also remember that in large doses, some antipsychotic agents and tricyclic antidepressants have anticholinergic effects. Next, go through the general steps of treatment as discussed in the introductory video. Note that these patients are prone for ileus, so be careful when considering decontamination measures. For the anticholinergic toxidrome, we have an antidote. It is called physostigmine, and it inhibits the breakdown of acetylcholine. Give 1 mg in 10 minutes intravenously whilst on the monitor. Be careful that you don't overdose your patient, causing bradycardia. Keep atropine at hand. That's all for the anticholinergic toxidrome. Share this video if you liked it. Thanks so much.